the jury has awarded the Kowalski family more than $260 million in this medical malpractice lawsuit against All Children's Hospital. Just hours ago, reacting to their victory outside the courthouse.
I mean, for the first time, I feel like I got justice.
After 8 weeks of testimony and evidence, All Children's Hospital is found liable on 7 claims, including false imprisonment, medical negligence, and wrongful death. The Kowalski family says the ruling sends a message.
Parents have rights, and they make the decision for their children.
The case has garnered national attention as the subject of a Netflix documentary. It depicts Maya Kowalski's battle with a rare disease and her family's experience at All Children's Hospital. Her mother, Beata Kowalski, was accused of Munchausen by proxy, medical child abuse, and doctor shopping. Maya, just 10 years old at the time, was separated from her family for 3 months. The family argues this prompted her mother to take her own life.
To me, it was about the answer, knowing that my mom was right. I want people to know that she wasn't harming me at all.
Chapter 1. This is where this story starts. On 9th of November 2023, Maya Kowalski, her father, and her brother were awarded over $250 million. To many, the outcome of the case was not a surprise. Many had watched a Netflix documentary called Take Care of Maya. This told the story of a young girl who had a painful medical condition. Indeed, the condition was said to cause the worst pain known to man. Her parents, Jack and Beata Kowalski, had tried hard to find a way to alleviate her suffering, including experimental treatments in Mexico. Then one day, Jack took Maya to Johns Hopkins All Children's Hospital with stomach pains, and instead of helping her and making her better, the hospital accused her parents, particularly Beata, of harming her. They called the Department of Family and Children's Services, and Maya was the kept apart from her mother, only being allowed supervised telephone contact. Because of their actions, a young child was suffering in a hospital without her mother there to comfort her. All because she had a condition that was so rare, the doctors did not know how to treat it, and instead of admitting that, they decided that Maya was making it all up, that it was all in her head, and Beata was the one behind it all. Eventually, the pain of being kept apart from her daughter was too much, and Beata took her own life. But I'm here to tell a different story. I'm not here to say that my account is right or wrong. First, I'd like to tell you a bit more about where it all started. Beata came over from Poland when she was in her late teens. She later met Jack, and they first had Maya, and then Kyle was born. Jack had worked for the fire service, and Beata was a nurse, and by all accounts, they were a normal family. That was until the summer of 2015. On 24th June 2015, Beata took Maya to see an allergist and immunologist who wrote, "She has quite the story of a severe asthma attack just last week. I sounds like a habit cough in a happy, well-appearing girl with normal lung sounds. Something doesn't fit here. Something is really not right. This is not just asthma. I wonder what role family dynamics are playing." Jump forward to 4th of July 2015, and Maya is cycling in a parade. But that evening, she is reported to have an episode that is best described by a neighbor who gave evidence in court.
I want to take you back to July 3rd, 2015, the neighborhood bike parade. Now, either that evening or the next day, was there an event that occurred involving Maya Kowalski that was unusual from your perspective?
Etched in my brain forever. So it was actually the night, that evening after the bike parade, and we got back to Jack's house. The whole neighborhood was there. And as soon as I walked in, I heard what was, it's a very difficult noise to describe. It sounded like almost gasping panic, but somebody being insanely hurt at the same time.
Did it sound like a child or sound like an animal?
It sounded like a kid. I almost thought it was a kid trying to make a terrifying noise. And I kind of chuckled like, what is that? And then I realized the look on these other adult faces was not panic, but, you know.
Was this the reaction when?
It was a reaction of fear of not knowing what to do. And then I realized it was a child. So I figured this was not my business or my place. Something was going on that was pretty serious. And I slowly backed out of the house.
And on 4th July, she was taken to Sarasota Memorial Emergency Department. They noted, last night she was getting worked up about the 4th of July, and when the fireworks began going off, she started having trouble breathing. Symptoms resolved on reevaluation, sitting comfortably in bed. She was then sent home. However, 2 days later, she was brought to the emergency department at Johns Hopkins All Children's Hospital. It was noted that she arrived in a wheelchair. Acute weakness, unusual presentation, and habit functional cough was also reported. In order for the rest of this story to make sense, certain terms need to be explained. These terms come from the Diagnostic and Statistical Manual of Mental Disorders. The DSM gives mental health professionals a shared way of talking about mental disorders, with each disorder having a list of criteria that need to be met to reach a diagnosis. One diagnosis relates to a somatic symptom disorder. A somatic symptom disorder is diagnosed when a person has a significant focus on physical symptoms. However, a medical cause for their symptoms cannot be identified. They may believe that the symptoms are serious, even when there is no evidence, or they may feel that medical evaluations and treatments have been inadequate. They may also make repeated visits to the doctors and spend much time researching their symptoms. We may all feel like this at times. However, what makes this a mental disorder is the extent to which the thoughts, feelings, and behaviors are excessive or out of proportion, resulting in major distress and/or problems functioning. Another diagnosis relevant to this story is a functional neurological disorder. Previously, the term conversion disorder was used. Patients with a functional neurological disorder may experience neurological symptoms, however, with tests showing no physical explanations to account for what they are experiencing. They may report symptoms such as numbness, inability to walk, paralysis, blindness, seizures, fixed position of a body part as being present. The symptoms feel very real and they cause significant distress or problems functioning, but the cause is psychological. As with a somatic symptom disorder, no deception is involved. So going back to the story, we know that on the 9th of July 2015, a doctor uses the term functional, meaning that they thought there was a psychological component to Maya's presentation. But only a few days later, Maya is brought back to the emergency department at Johns Hopkins All Children's Hospital with the symptoms including diffuse pain and weakness throughout her whole body. Whilst she is noted to report severe pain on attempted movement of any joint, nothing physical is seen to account for this. One possible diagnosis is recorded as psychological pain, conversion disorder, somatization, and it is noted that she is kept in hospital for further assessment. However, she is then discharged as the patient's parents want her to be transferred to an outside hospital. Jack and Beata then take Maya to Lurie's Children's Hospital, where she was an inpatient from July 21st to 24th. Physical tests are unremarkable, and again, the term conversion disorder is noted. So, in less than 3 weeks after the 4th of July parade, Maya has been brought to Sarasota Memorial Hospital, Johns Hopkins All Children's Hospital, and Lurie's Hospital in Chicago, all of which have not found a physical reason for her symptoms other than loss of muscle tone from being in a wheelchair. Instead, psychological pain, conversion disorder, and somatization are recorded by physicians, something Beata is reported to strongly disagree with. 3 days after being discharged from Lurie's Children's Hospital, Maya is brought to Tampa General Hospital. Whilst the concerns about the cause of her presentation being psychological remains, she is admitted for further assessment, for example, a nerve conduction study, which comes back normal. However, as Maya is not using her legs properly and is seen to be deliberately turning her feet inwards, the focus is on physical rehab to build up her leg muscles after lack of use and use of aids to reposition her feet. The next chapter is Maya's account of events from July to August 2015.
What happened over that 4th of July weekend that changed your life?
I had a severe asthma attack, and it was one of the worst asthma attacks I've ever had. I was taken to Johns Hopkins All Children's Hospital, and I think I stayed there for a couple of days, if I'm not mistaken.
Well, the jury needs to know how this came on. You just wake up one morning and bang, you were in extreme pain? Or how did it start?
It wasn't like that. It was pretty gradual, but not in the sense that it took like 3 months until I had excruciating pain. It was day by day I noticed that there was a pain in my right leg that was just getting worse and worse.
During this was it just in your right foot and leg at this point?
At this point, no. It had traveled to the left leg as well.
So about how long did that take for it to...
It would have been 3 days then. Well, after this day, I know I went home, but then I was at one point transferred to another hospital.
Was that the one back up in...
Illinois. It's really hard for me to remember. I was 10. Every hospital was the same to me at that point.
Tell us what's going on here.
This is after I got off the plane that I landed in Illinois. My dad had some of his old firefighter friends pick me up off the plane and transfer me in an ambulance. And then the chief, I believe, went to baggage claim and got my mom and I's luggage.
All right. So do you recall what they did for you there at Lurie's?
I know that they suggested an intensive physical therapy program, but they also missed the diagnosis of CRPS.
Did you go to another hospital after that?
Yes, my parents had taken the suggestion from the Illinois hospital, and we went to an intensive physical therapy program at Tampa General.
Had anybody approached you at this point at Lurie's and said anything about this just being all in your head?
I found that out later.
And was it in your head?
No.
And what did they tell you about why you had to do the PT?
Well, none of the doctors knew what was wrong with me at the time, so they just assumed that strengthening my muscles would maybe help get me to walking again.
All right. And were you outpatient or inpatient?
I was inpatient, yeah.
So you stayed there?
Yes.
And you remember for about how long?
A month. Even though she was a nurse, she believed that I had either conversion disorder, so I was like making out my disease. I don't know what child would want to pretend not being able to walk and not being able to play with their friends, but she drew that conclusion.
And at this point, were you completely in a wheelchair?
Yes.
And did there come a time when somebody did know what was wrong with you?
Yes.
The next few chapters in this story concern Dr. Kirkpatrick diagnosing Maya with complex regional pain syndrome, or CRPS. First, we look at what is CRPS. Complex regional pain syndrome, or CRPS, formerly known as reflex sympathetic dystrophy, or RSD, is a chronic condition that causes persistent burning pain and swelling in the arms, hands, legs, or feet. The body's normal response to an injury begins when pain receptors deliver pain messages in the form of nerve impulses to the brain. Once these impulses reach the pain centers in the brain, the pain centers generate new impulses and send them through the sympathetic nervous system to the area of injury. The sympathetic impulses trigger an inflammatory response, causing blood vessels to expand. The inflammatory response also leads to swelling and redness in the damaged tissue. As the wound heals, the swelling and redness subside and the pain goes away. However, if a person has complex regional pain syndrome, the pain and swelling do not go away after the wound heals and may worsen over time. While CRPS typically develops after a minor injury such as surgery or fracture, an inflammatory response due to illness is also seen to be a contributing factor. CRPS is a syndrome, not a disease, and there are no laboratory tests that can definitively confirm or rule out CRPS. The diagnosis is made following a physical exam and taking a medical history. The Budapest criteria for a diagnosis of CRPS fall into 4 categories: sensory, vasomotor, pseudomotor, and motor, as well as pain disproportionate to the inciting event, asymmetrical skin color and temperature changes, swelling and sweating changes, skin changes, and a decreased range of motion may also be present. There must be one sign in 3 out of the 4 categories and at least one sign in at least 2 categories at the time the person is being assessed. For CRPS to be diagnosed, no other diagnosis should better explain the symptoms. There are 2 types of CRPS. CRPS type 1 used to be called reflex sympathetic dystrophy, or RSD. In CRPS type 1, there is no nerve injury in the affected area. CRPS type 2 used to be called corsalgia, and there's a clear nerve injury. CRPS type 1 accounts for the vast majority of CRPS cases. The treatment of CRPS is typically pain medication, physical and occupational therapy, and psychosocial support. A physical therapist called Paul Marquis provides a useful insight into his experience of helping people with CRPS.
This is one of these complications that can be life-altering and can cause chronic pain to a person the rest of their life. It can be very, very disabling and take them out of work. They can have major depressive disorders because of this, and just total loss of function. There are basically two types of complex regional pain. The first type, which it was kind of always used as reflex sympathetic dystrophy. It's always been called reflex sympathetic dystrophy. This type usually occurs after some sort of an illness or an injury that does not affect the nerve in the peripheral aspect of your body, like an affected limb or something like that. About 90% of the people with complex regional pain syndrome have this type 1. This type is more likely to respond to conservative management and get better, and sometimes even just kind of get better on its own over time. Not really as severe as type 2. And type 2 is a lot rarer, but usually caused when there's some sort of damage to a peripheral nerve. It seems to be more common with crush injuries, but not always the case. It can happen post-surgically. It can happen just from a mild injury, but usually a type 2 is affected mostly because the nerve has been compressed and injured. So this here will also give you the most disabling type of complex regional pain. Usually you see complex regional pain syndrome in the foot or ankle and the hand. I have seen it in the knee on occasion, very rare in the shoulder and elbow, but these are all areas where you can have this. So what are some of the signs and symptoms, and who are the people who are more apt to get complex regional pain syndrome? Well, what is it, first of all? It's very complex to try to understand the nervous system and how it functions when you develop complex regional pain syndrome. But this is what patients present like. They have this injury, and they have this disproportionate amount of pain for the injury that they sustained. Okay, so you see these people that they have an ankle sprain. Most of them get better 99% of the time. They will improve with physical therapy. They'll improve with some orthopedic consult and maybe medication, non-steroidal anti-inflammatories. But on occasion, and I've seen this, people develop complex regional pain, and you touch the foot. It is super, super sensitive. They can't move it. It's painful all over. And it's just an unusual presentation. But the thing that you need to recognize here, and this is probably the most common thing with complex regional pain, is that there is a disproportionate amount of pain for that particular injury. So they're very, very hypersensitive to touch, and especially real hypersensitive to cold. The other thing you're going to notice is usually some sort of a flexed positioning of the extremities. In the hand, the wrist will be flexed a little bit. The fingers will be in this general flexed position, sometimes almost closed, and it's very hard to extend. The wrist joint, the ankle joint will be very uncomfortable, and the foot will be in kind of a plantar flex position at rest, more so than the other side. There's often an unusual amount of swelling in the hand or the foot, and it's not just interstitial swelling at the area of injury, but throughout the whole area, and that's kind of a giveaway also. And oftentimes you'll see some hyperhidrosis or an unusual amount of sweating in the foot or hand or extremity that has been injured. That's also quite common when it comes to complex regional pain. The other thing you'll notice is some skin discoloration. You'll see some redness, sometimes bluish color, and very oftentimes the skin will be mottled. You'll see like these little circular patterns in the skin that look very unusual. And as far as diagnostic testing goes, there's really not a lot of great diagnostic testing out there that can identify complex regional pain syndrome. To treat this, you get a medical team together. You cannot treat this alone. So you get the PCP involved. A physiatrist is always great to have on board when treating complex regional pain. You need a psychologist involved here, and somebody who works especially with chronic pain syndromes, you'll want a physical therapist, occupational therapist working with this person, because you ultimately want to start to gain some motion, do some retrograde massage. Things like gabapentin, Neurontin also are very helpful with nerve-related pain like this. Get a team approach involved, and then everything should be positive and goal oriented, and you will do well with these people. These people need to be seen often. They need to be managed medically and physically and psychologically, and you can succeed with these people. They just need to be well taken care of, and you need to be in charge of getting the group together. And
Whilst it is clear that CRPS is a very real syndrome to many, there is also a lot of controversy regarding overdiagnosis, particularly when it is not associated with a physical injury. For example, Chang et al., 2021, state pain is not quantifiable or measurable. It is a subjective symptom, not a disease. In a study of 50 consecutive CRPS patients who were involved in litigation in the United Kingdom, the investigators found that somatoform disorders, as defined by DSM-5, were found in 42 patients. The prominent role of litigation and compensation seeking in a large proportion of CRPS patients means that their symptoms are often reinforced and prolonged by the legal system. As also noted by Lawson et al., 2021, it is unclear if psychological factors confer risk for the development of CRPS, or whether some patients, once diagnosed with CRPS, develop mood disorders. Now, CRPS has been explained. Let's go back to the story. Where we left off, within 2 months of a 4th of July parade, Maya had attended Sarasota Memorial Hospital, Johns Hopkins All Children's Hospital, Lurie's Children's Hospital, and Tampa General Hospital, all of which suspected that the cause of her symptoms was mainly psychological. However, she spent nearly 4 weeks at Tampa General Hospital receiving physical therapy to build up her muscles as she remained in a wheelchair. A psychologist at Tampa General Hospital also noted, Dad realizes that much of her behavior is filled with exaggeration. She was then discharged with a physician noting suspected conversion disorder. Beata, though, was reported to strongly disagree with any suggestion that there was not something physically wrong with Maya. This is where the story really starts. Beata hears about Dr. Kirkpatrick. Dr. Anthony Kirkpatrick is an anesthesiologist. He undertook his first degree in 1966, then completing a master's in pharmacology, and then a PhD. In 1983, he qualified as an anesthesiologist. Anesthesiologists administer anesthesia, manage pain, and ensure patient safety during surgery and other medical interventions. Dr. Kirkpatrick is not board certified. Board certification tells the public that a doctor has undergone additional years of specialty training and education in order to practice medicine. It is not a mandatory requirement and is entirely voluntary. Dr. Kirkpatrick provides ketamine infusions for people with CRPS. In 2006, he put in a proposal to provide ketamine comas in Florida. However, the study was not approved. In 2008, it was also reported that a number of patients with CRPS has undergone ketamine comas in Germany, however, with the research not continuing. Dr. Cantu, a colleague of Dr. Kirkpatrick, now administers ketamine comas in Mexico, and Dr. Kirkpatrick provides ketamine infusions in Florida. Dr. Kirkpatrick may also refer patients to Dr. Cantu. Both Dr. Kirkpatrick and Dr. Cantu receive patients worldwide. Neither, however, are noted to be contributors. The main textbook on CRPS, Complex Regional Pain Syndrome, A Clinical Guide, 2021. There are 51 authors contributing to this book. One patient of both Dr. Kirkpatrick and Dr. Hanna was called Jessica. On the 20th of September, 2015, Beata wrote to Jessica. She said, "I'm a friend of your dad. Actually, I was his nurse. My daughter Maya, you probably have heard of her through your parents. She's been unable to stand or walk since 4th July 2015. She is sitting better and balance has improved, but her pain is still severe, along with fixed dystonia, spasms, and allodynia to her legs, plus severe headaches. We're going to see Dr. Kirkpatrick next Wednesday." We know, though, that whilst Beata did not take Maya to see Dr. Kirkpatrick until 23rd September, on the 16th September 2015, she told a pulmonologist that reflex sympathetic dystrophy is the most current diagnosis. Reflex sympathetic dystrophy is the previous term for CRPS, and Maya had not been diagnosed with this at this time. Because Dr. Kirkpatrick videos his assessments and puts them on YouTube, we are able to see his assessment of Maya. However, before looking at the assessment of Maya, we will first look at 2 other videos of his assessments. One is assessment of a young girl called Elizabeth, and the other is of a child called Hannah. First, the assessment of Elizabeth.
Is February 3rd, 2014. You're here for a 4-day ketamine infusion. Back in October 2013, you had a tetanus shot done in that left shoulder area, correct? Mm-hmm. I want you to start up here on your leg, okay, and I want you to work your way down. Remember how I showed you? Nice light strokes like that. Close your eyes. And when you get to the area in that leg where it feels like road burn, remember the road burn signal, just stop and point with your finger. Okay, go ahead. Get started. There you go. Go on down. Atta girl. Good job. Let us know when you get to that road burn.
Right here.
You hit it right on the nose, girl. Right on the nose. Okay, very good. And of course, you're going to have the same problem on the other side. Go ahead and do that just for your own satisfaction. Go ahead. Work on down. Atta girl. When you get to that area that feels like road burn, just stop. Right, there you go. You cannot weight bear safely. Okay, we know that. But what I want you to do, you see where your mom's sitting? She's going to get out of that chair and she's going to spot you to make sure it's safe. And I want to see what you can do on your own and transferring yourself as much as you can on your own from that chair over to the wheelchair. Do as much as you can on your own. Mom is watching you. Atta girl. Good job. All right, very good. Good job. Good job. Elizabeth, I want you to look over here at Grandma. Grandma has some questions for you.
Grandma.
Here's Grandma. Here's Grandma over here.
Hi, Elizabeth.
She has some questions. She has some questions for you. Go ahead.
Do you remember what I noticed about your grandmother?
Elizabeth.
It's okay.
Elizabeth, can you answer Karen's question? She asked you a question. Do you remember the question?
I noticed that there's a green lizard outside. Can you tell me what I noticed was outside?
Okay, so today is February 11, 2014, and your last ketamine infusion was on a Saturday. And so now we're about 2 to 3 days beyond that point.
No concerns. In fact, midway through the second infusion, I was comforted when she told me that the burning pain was all gone.
Yeah.
As she was trying to pull out her IV, I'm done. She
Yeah,
says
right.
no.
Right.
It was emotional. It was hard.
Yeah.
But it was a very positive experience, especially compared to the last 4 months and 4 days that
Yeah.
this took a toll on her life.
Right.
It stopped.
Exactly.
Well, and I think it's interesting to note that the CRSP, the RSD, actually changed her ability to work with us. She didn't used to be combative and refusing to do things like a 2-year-old like that.
She became very 2-year-old-like
Yeah.
behavior. You couldn't reason with her, you couldn't talk to her. And that started the minute the RSD started.
Yeah.
It was like I couldn't reach her. It was why I think a lot of doctors thought that this was psychological based and not anything else.
It didn't happen to her, but I'm telling you, I've seen it more than once. Many times I've seen it in kids. Not so much in adults, but in kids. And what happens is the stress from the pain becomes so severe that there is a protective mechanism that sets in. We call that a conversion reaction. And what that is their legs can become paralyzed. They can't move. They may even lose the ability to feel things in their legs. Sometimes they can go blind. They can't see.
Let's look again at the signs of CRPS, this time summarized by the Harvard Medical School. In the earliest stage, days to weeks after an injury, the limb can become dry, hot, red, and painful. Even the lightest touch or the slightest movement can cause excruciating pain. Over the next few weeks to months, the skin can become shiny, thin, and cool. The limb becomes mottled and purplish. There is considerable swelling. Pain worsens. Some people experience other movement problems, including weakness, spasm, and tremor. An affected limb can become permanently flexed or bent, contractures. In some people, the skin can become tight, dry, and shriveled. The skin, muscles, and joints stiffen so that the affected area cannot be moved. Once the disease reaches this point, it is extremely difficult to treat. CRPS does not cause paralysis. CRPS does not cause a conversion syndrome. If a person with CRPS has limited movement so that they cannot walk or their limbs have contracted, the severity of their condition would likely be considerable, and there would be other observable signs, such as swelling and skin changes. The next video is of Hannah. Her case is featured by Dr. Kirkpatrick in a series he called Do Doctors Torture Patients?
Looks like she's got the CRPS, and the conversion reaction is what any normal human being would do when they're put under extreme stress and extreme pain, and it's not something she has no control over whatsoever. We see this a lot in patients that have CRPS. Talk a little bit about what a conversion reaction is. By definition, a conversion reaction means you've got some kind of thing going on, usually a movement disorder, and of course a seizure-like activity or movement disorder is a movement disorder, okay? But you can't explain it on an organic basis, okay? It doesn't follow the dermatomes, the wiring in the body, and so forth. So these doctors didn't have enough knowledge, enough skill. They just weren't competent enough to recognize that. And unfortunately, when doctors can't figure something out, it's easy for them to say it must be an emotional, it must be purely a psychological thing, okay?
Yeah.
You're not going to do a conversion reaction while I'm standing here. I'd like to get that documented. And so the plan here is to do a 4-day ketamine infusion. By the way, this is a PICC line they have in you right now, and it looks like it's not sutured in. It's so that's good news. We have to keep an eye on that, you know, for any evidence of infection, that kind of thing. We talked about that risk,
Yeah.
so we're going to. And you're a nurse, so you know exactly what I'm talking about.
Yeah, I'm looking after it.
Right.
Correctly so far.
Right, exactly. What I want you to just take that right hand behind your head, see if you have any pain. Any pain when you do that?
No.
Do the left hand, please. Any pain when you do that? No. I want you to see if you can wiggle those toes for me at all. Just give it your best try. I don't see any action there. You getting anything? See if you can bring your knee off the ground here. Can you bring your knee off the bed? No, you can't even move it, can you? Now over here on your left side, again, the same thing. Let's do your toes first, so you can wiggle those toes. A little bit of movement there, huh? Okay, very good. See if you can bring that knee off the bed a little bit. Can you do that? All right. And just to summarize, they can't do it. So just to summarize, from your waist on down, you got allodynia throughout this whole area, correct? Mm-hmm. Real sensitive skin. Okay, very good. Just pick it up from where she came back and she was paralyzed, she couldn't move her legs, and take it from, just give us a brief synopsis of how things have been going.
Yeah, we reversed the paralysis with a 4-day ketamine infusion.
But as you didn't even know you had it spreading down into your leg and into your face until we actually did these measurements on you, right?
Yes.
So another thing is, unless the doctor really does a careful examination, they don't appreciate that this is a disease that can be widespread. And in your particular case, practically the whole left side of your body. The doctors down there said this is all a psychological problem. This is a psychologically induced conversion reaction, right?
Yeah, versus malingering.
Malingering, right, which is not a diagnosis, that's an accusation, isn't it? So what we can do here is we can say, another conclusion, we can say this is RSD related, and all the doctors that gave all this false and misleading information, they're the ones that got a psychological problem, big time. There are some doctors who actually torture patients that have CRPS. Now, if they're doing it intentionally, of course, that's a crime. But a lot of times, most of the time, it's unintentional, and it has to do with their ignorance. They don't know what they're doing. Doctors, some doctors, actually torturing patients, and we discussed that earlier, where if you torture a patient, physically torture a patient, or even mentally torture a patient, it's a crime. There are instances, and I think this is one of those, where you were tortured. Not necessarily intentionally, because the doctors were just ignorant. And when the stress is being generated by a doctor not giving you adequate pain control, as in my opinion what's going on here, it just adds to it. Now there is evidence to support what I'm saying, not just the anecdotal thing I said earlier about tying, like in prisoners of war, tying piano wires to men's testicles and actually kicking them in the testicles, causing serious injury. But there's now very solid evidence that if you stress a patient, particularly in torturing them, you can trigger a conversion reaction. And as you've learned, when we do something very specific to treat your pain, give you the ketamine, which I asked them to do, which they refused to do in the hospital. When I gave you the ketamine, all of this reversed. When you accuse a patient of making something up, feigning, malingering, that's not a diagnosis. It's an accusation.
They started to accuse me and Andrew and decided that we were reinforcing her symptoms and suggested that if we stepped out, that her symptoms would improve when she has less stimulation and feedback. It's a big regret that Andrew and I did step out for that one night, because that was the worst night for Hannah, and in fact none of that happened, and yet they still disregarded what happened going forward. Her other leg converted and she was paralysed then in both legs after they had suggested that Andrew and I were somehow also responsible for causing this.
So the point is, when doctors are ignorant, they don't understand something, they always are looking around for some kind of excuse besides their own ignorance. Blame the mother, blame the husband.
To recap, conversion disorder is a mental disorder listed in the DSM-5. Symptoms include altered voluntary motor or sensory function with an incompatibility between the symptoms and medical conditions. It can include not using a limb. It is not a symptom of CRPS, and it is not treated with ketamine. A person presenting with a conversion disorder, also called a functional neurological symptom disorder, is assessed and treated within mental health services. They are not assessed and treated by anesthesiologists. We can now look at Dr. Kirkpatrick's assessment of Maya, which led to a 4-day ketamine infusion, and after that to a ketamine coma in Mexico.
A 10-year-old pediatric child undergoes a 5-day coma to treat intractable chronic pain. Why? Pre-evaluation.
So let's go over your history just a little bit, okay? Approximately 3 months ago, you started having some pain down in your feet here, okay? Here's what's important to understand, is that there is no particular injury we can attribute this to, okay? Also, another thing that's important to note is that with that, she noticed different fluctuating temperatures between the two sides. In other words, sometimes one side would be colder, sometimes one side would be warmer. And sometimes one would be more red than the other, but it would flip-flop back and forth, okay?
Or purple.
Yeah, or purple, right. So this is typically what we see with RSD. But she has some other features that suggest that this is just nerve pain, that it's more RSD. The fact that it did tend to spread. It started down there, and then she started getting some tingling in her upper extremity, but that seems to be improving in recent times. Is that right?
Yes.
Yeah, right. And also, you see how her legs are turning in. That's typical of what we see with the RSD. We call that dystonia, okay? Dystonia. In fact, it's so bad right now she can't even bear weight safely by herself. It won't happen. It won't happen, okay? And she also has this thing that's characteristic. She has the allodynia. We're going to talk more about that in a little bit here, but that's why we marked her down here in her leg there, is because she's got that. As she goes down, it starts to feel like road burn, right? Maya. Did I finally say it right? Yeah. Did I say it really right?
Yeah,
okay.
Doing so much better.
Okay, you ready for some testing?
Yeah.
Okay, 2 vertical fingers in your mouth. Atta girl. Good job. Are you having any pain when you do that? Right there. Now you're pointing underneath your eye there. Do you have the same pain on the left side, or is it only on the right side when you open your mouth like that?
It's a little better on this side, but it's
much worse over there. Oh, good job. Good job. Okay, very good. Now the next thing I'm going to ask you to do is to take that right hand as best you can and see how far you can get it before you have to stop, okay? Behind your head. Atta girl. Bring your head up straight. Straighten your head as best you can. You don't have to go all the way. Just we want to know what you can do. Remember? Okay. That's it right there? Very good, Myra. Now the next thing I want you to do is tell me. You can point with your other hand. Where did you feel the pain most intense when you did that?
I felt it in my shoulder and by my elbow.
And your elbow. But your hand was okay?
Yes.
Or pretty much. Okay. Now I want you to do the same thing with your left side. Can you do that? Atta, keep your head straight now. Maya, keep your head straight. Atta girl. There you go. Now, you're doing better there, aren't you? And where do you feel the pain when you do that?
It's the same as the
Same on the shoulder. Yeah. Very good. Now the next thing I want you to just take that right hand out in front of you, please. Open and close it as fast as you can. Atta girl. Good job. Good job. Now where do you feel the pain when you do that?
My wrist and some of my fingers.
Does it get above your elbow when you do that?
Just a little bit.
Just a little bit? Okay, good job. Now I want you to do the same with the other side. Open and close as fast as you can. Atta girl. You're a little faster there, aren't you? Yeah. And where do you feel the pain when you do that?
My wrist.
Okay, very good, very good. And now this tingling, you're still having this tingling going on?
Yeah, my
But-
fingers.
But not as bad as it was before, still a little better. Is that correct? Okay, excellent. Good job. Now, the next thing we want to do here, Maya, is you see how we got you marked here? I want you to close your eyes. Bring your little trousers back a little bit. That a girl. I don't want, pull over here, hold that back so she doesn't have to think about doing that. Just hold that back so we can get you. I want you to start up here where you don't feel it, and I want you to come down, okay? Go ahead. Close your eyes, you with your finger, nice and slow. And again, you stop when you think you get to where, right there? Very good. Don't look. Now I want you to start over here. See where my finger is? Start over here and do the same thing. Stop when you get into it, okay? Keep your eyes closed.
Right there.
Perfect. Good job. Finally, we want you to start right there and do the same thing. Atta girl. Good job. Stop when you get to it.
Right there.
Good job. You did a great job. Perfect. Now, next thing we're going to do is going to ask your mom to help you. She's going to get over here, and she's going to hold your foot up. Oh, go over here first, please, on the right side. She's going to hold your foot up, and she's going to ask you to try to wiggle your toes as best you can, okay? Can you do that as best you can? You giving it everything you got there? Is that right? I can tell by looking at you. You're giving it everything. Okay. Now, we want to see if you can rotate your ankle for us. Can you do that? Can you do that? Okay. Mom, you don't see any movement, do you?
No.
Okay, very good. Now, Mom, I want you to get on the other side. We're going to do the same thing. Then we're done, okay? You're doing a great job. You're doing a great job. Okay. Again, Mom's going to lift it up so we can see if we can get any movement at all in those toes. See if you can move those toes for me. A little bit, not much. Okay, now see if you can rotate your ankle in your mom's hand. Can you try that? Not much, huh?
But it felt a little.
She felt, your mom says she felt a little, right, Mom?
Yes.
Okay, Mom, very good. Good job. You can put that down. Now, Myra, would you like to have a blanket or something over your legs, or are you okay like that?
I'm okay.
Okay, Mom, have a seat, please. Okay, so don't worry. I don't pick on moms. Only a little, a little one. Come over a little closer over here. Okay, very good. So tell us about her life. You know, she was in gymnastics. She was doing a lot of stuff before this all happened. So tell us about that.
Yes, Maya was very healthy. She started with ballet classes at about age 3. Then she started playing piano at about age 4. She got tired of doing ballet, and we started ice skating. So she was on a team, on a synchro team, and she won many medals with her team. We traveled to Wisconsin. I think they got about, I don't know how many gold medals, her team, and some silvers. Did you get one silver? And how about bronze?
Never.
No, never. They were one of the best teams. They did very well. And then she wanted to do gymnastics. So she was...
About what age was she when she wanted to do the gymnastics?
Gymnastics was about age...
She's 10 now.
6. I would say about age 6 is when she just started to take gymnastics classes.
Okay.
And at first, I think she was doing the classes maybe twice a week.
Okay.
And then she kept on getting better and better, and she wanted to do more and more. At one point, she was doing it 3 times a week when she could, because we didn't want her to slip in her school studies.
Right.
And she kept insisting on getting on a team. So we struggled about the decision of being her on a team. But she convinced us, and we let her be on a team. And I was here in Florida. We got her on a team, and the team was 4 times a week.
I see. Great.
And that was very strenuous on her asthma.
Right, and that's another thing we talked about. She has what we call more than just average. She has a pretty severe case of asthma, right?
Yes, it's a cough variant asthma, which is rare, and it took us a while to determine what kind of asthma it was. But it's a cough variant asthma, and it's treated a little bit different than regular asthma.
So tell us briefly how it's different.
She doesn't.
By the way, let me just in case you want to share this with someone, everybody needs to know you're a nurse. Okay,
I am a nurse.
You're an RN.
Yes.
So if you're using the big words, everybody kind of bear with you. Okay.
I will try not to.
No, that's okay. You're doing good. You're doing good.
So with the cough variant asthma, she hardly ever has any wheezing.
Okay.
Her asthma symptoms are cough. And the cough will get progressively worse.
I see.
To the point that it might be happening every 2 to 3 seconds.
Oh, really?
And at that point, that means it's really bad.
I see.
And we're trying to do everything to break that cycle.
Tell us how you try to break a cycle.
At this point, we're using Tussinex for the cough, Benadryl 10 mLs right away, Pulmicort.
And how are you giving the Benadryl?
It's liquid.
Liquid, okay.
Liquid, 10
Orally.
mLs,
Okay,
oral.
okay.
And she has gotten it sub-Q when she was very severe. I have administered it sub-Q to her.
Okay.
And then we're starting, she gets 4 puffs of albuterol. So like the first 3 drugs are 4 puffs of albuterol, Benadryl 10 mLs, and Tussinex 2.5 mLs.
Right.
And then we do her Pulmicort or Duonab, depending on her symptoms. I kind of feel like the Duonab is working better, so I tend to give her the Duonab first.
Right.
And it's a nebulizer. She will get that, and that can be given every 8 hours as needed for her symptoms. And then she gets Pulmicort, which is once a day, but she can get up to 4 vials maximum if her symptoms do not subside. She has lots of allergies, so allergies stimulate her asthma. She's got severe allergies to the environment, to the grass, to the trees, dogs, cats, severe allergies that bring up her asthma attacks. And she has she gets sinus infections. She's got Ig selective immunodeficiency, which make her less her body doesn't fight as well the infections that come upon her.
Right.
So with that being said, last week we had a really hard week, or maybe a week and a half, I should say, because she developed a sinus infection, which automatically led to asthma attacks. And the first day of this episode was very severe. We thought we were going to wind up in a hospital again because it was very difficult to break the pattern.
Right.
But I did. I was successful. I stayed on top of it, and I broke the cycle.
As is found in many pediatric patients, the inciting injury that triggered the CRPS is difficult to identify. The patient was becoming progressively more incapacitated. The patient had many comorbidities which would complicate her treatment, such as asthma and with possible immunodeficiency. 4-day ketamine infusion outpatient. The patient tolerated up to 135 milligrams per hour of ketamine without any serious complications.
That's not unexpected. And I would say she hasn't had any adverse hallucinations. Would you agree with that?
I agree with that.
Okay, all right. So Maya, there's one question. Are you ready? Show me the sign, Maya. Show me the sign. There you go. Hey, she's got it. She's got it. She's got it. So we just did your pain thresholds a little while ago, and there was clearly an improvement there throughout your body. Okay. Now, are you ready to do some testing? Do 2 vertical fingers in your mouth and tell me you still have that pain under your eye, and if so, if it's the same or if it's decreased. Go ahead, tell me.
It's the same.
It didn't improve? Can you open your mouth better now? What do you think?
It hurts a lot more when I open my mouth.
Well, I know, but we're talking about how it compared to where it was before we gave you the ketamine, okay?
It's about the same.
Yeah, all right. If it's difficult to tell, it's difficult to tell, okay? Now, the next thing we want you to do is we want you to take that right hand and sit straight and see if you can get that hand behind your head a little easier now. Do as best you can, right? Right about there? That's it? Okay. And where do you feel the pain when you do that?
On my shoulder.
In your shoulder? Okay, very good. Is it seem about the same, or is it less, or what is it?
I don't really remember.
That's fine. That's fine. Remember, we just did it just a few moments ago. We had put you through some exercise, so we kind of got her worked up a little bit from that prior exercise we did on her, some testing. Now do the left side for me. See if you can get that up a little easier now. Well, you couldn't get it quite back there before. You're getting a little bit better with that. Okay, very good. Again, it's his shoulder that's causing a lot of the pain. Okay, very good. Got it. Take that right hand out in front of you. See if you can open and close a little faster now. See if you can get that open and closed. Seem a little better there? Yeah. Now do the left side, please. There you go. Good job. Good job. Now, Mom, come over here and so we can see that black mark on her leg. Can you get that back for us, please? I'm going to see if, okay, I want you to close your eyes. Remember how we did that? You're going to go above the black line, so let's get it up there.
Close your eyes.
Wait, right here? I see.
Yeah.
Start right there and close your eyes.
Close your eyes and work your way down until you get to that area that feels like
there.
right there. Okay, now take another area. That's right, over there. Now work your way down.
Right there.
Okay, very good. Now do the inside of your thigh over here.
Oh, wait.
Yeah.
The other side. There you go. That'll be it. Go down until you feel it. Right there? Okay, very good. I would say it's really hard to tell that there was a real shrinkage there going on, okay? It's kind of hard to tell.
Yeah, maybe a little bit.
Maybe a little bit, right. And I think the comment was that you, from a subjective standpoint, you feel she's sitting better, sitting up easier now than she did before. Now, next I want us to see if we can get any, Mom, why don't you come down there and get that foot so we can do some testing down there on that foot action. See if she's got any motion in that foot there. Go ahead and see if you can rotate that ankle for us, okay? There we go. Okay, rotate the ankle. See if you can get it. Any movement there, Mom? Okay, try to wiggle your toes for me. Can you do that? Can't do it. Okay, very good. Now, and I'm recording. Look at me. Look at me. Okay, now do the other side. Okay, will you need a rest or are you going to be okay? Okay, see if you can wiggle those toes for me.
There was a little wiggling.
Yeah, a little bit of wiggling there. Now try your ankle there. Little movement there?
Yeah, a little bit.
Okay, very
Tiny
good.
bit.
Tiny bit.
Stop touching.
A little bit is enough. Yeah, that jerking is kind of typical of what we see, when they get, a lot of pain, going on.
Why did the family decide to go forward with a 5-day ketamine coma? The mother said Maya was getting worse. She couldn't move. She couldn't roll in her wheelchair. It was constant agony of pain 24 hours a day. No sleep, no eating, no drinking. She started to have abdominal pain. She had to start IV hydration to help her at least get some fluids because she wouldn't even touch the water. She couldn't even take pills anymore because everything was hurting her. Maya had said several times that she would rather be in a coma or die than continue like that.
Does this fairly and accurately depict Maya participating in one of these procedures?
Sí. Yes.
And the equipment around her, what all that is in terms of monitoring Maya?
Yes, on Maya's right side we see a piece of equipment for mechanic ventilation. On the left side we can see different infusion pumps.
There has been some discussion here about warnings of this procedure as a 50% chance of death. How does this relate to any other medications that might be used to treat this illness?
Predicting risk of a severe adverse effect is very hard to do. It's like when you're going to have a certain procedure and require general anesthesia, there's definitely a risk of some severe adverse effect. When we get to the use of ketamine is before all prior treatments have failed.
How many patients had you given it to?
Most likely it was more than 25 patients.
And was this the youngest patient you'd ever treated this way?
To my recollection it was.
Oh.
Correct. Correct.
And so, and that was because the coma is a sort of last resort, correct?
Correct. Correct.
And that's because it is a high-risk procedure.
It has a high risk.
And you tell every patient that.
Y usted se lo dice a cada paciente.
Correct.
Correct.
And that's not just because of the ketamine, that's also because of the intubation.
Así es. That's right.
And the length of the intubation.
Correct. Correct.
And the impact of ventilation for 5 days.
Yes. That's right.
And then the risk of infection from all of that.
Yes. That's right.
And then the effect of all the other drugs besides just ketamine.
Sí. Right. Yes.
Is a medical coma a highly controversial and unacceptable procedure?
If it is controversial, probably it is. These are all patients that have a very poor quality of life, and these are patients that in many cases have a tendency to suicide.
How many referrals has Dr. Kirkpatrick provided your office?
25, 30.
Has he lost patients, or does he know of patients who have died from CRPS without treatment?
I met a patient who came to coma. She was 3 years out with a completely normal life. She got a scholarship to continue studying, but then had a relapse. After that, she had a fall from her bed, fractured the leg. There were then no resources to continue treating her the way she had been treated prior to her problem. Progressively, she lost the ability to feed herself. We had to use with her IV analgesics for pain, and she finally passed.
Beata kept a public blog where she would put photos and provide updates on Maya, writing as if she was Maya. These are some examples of what she wrote. So far, I am the youngest child in history who has developed severe, generalized RSD in a very short period of time, and I am the first youngest child in history who is going to be placed in a high-dose ketamine coma. This procedure is very high risk in my complex case due to the fact that I have immunodeficiency, very poor nutritious status, and now severe adrenal insufficiency. I was told today I am a high-risk patient for developing infection or sepsis during the coma, difficulty weaning off of the ventilator after coma, needing blood transfusions, and total body failure or death as a result of adrenal insufficiency and other complications. In this blog, Beata, writing as if she is Maya, talks about the risks of developing sepsis during a coma. Sadly, Jessica, whose father told Beata about Dr. Kirkpatrick, died from sepsis in 2018. She underwent many ketamine comas administered by Dr. Cantu, a risk of the comas being blood clots. Her blog shows how she had to have her leg amputated when in Mexico, her parents then writing about her death due to sepsis. This is the patient Dr. Cantu will have been talking about, and it's clear that the loss of her friend would have been very hard for Maya. Maya also told us about the choices she had to make as a 10-year-old child.
You'd been through physical therapy, occupational therapy, psychotherapy, warm water therapy, opioids. Now you were trying ketamine?
Yes. He called Dr. Cantu. He's a doctor in Monterrey, Mexico. Well, I was presented with the worst case scenario, which was a 50% chance of death. Even though that's not completely true, they always give you the worst case scenario just in case something bad happens.
Had you heard that with other medications and things?
Yeah, I mean, every medication has like a ton of side effects.
Knowing about the risk, you and your parents, did you talk about whether you wanted to do this?
Yes, they specifically asked me, and I know I was really young at the time, but they gave me pretty much full authority of whether I was going to go through with the prolonged sedation or not.
Maya went to Mexico for a ketamine coma in November 2015 and ketamine infusions in December 2015. In January 2016, she was seeing Dr. Hanna, an anesthesiologist, for ketamine infusions. In total, she had over 50 ketamine infusions with Dr. Hanna. She also had 40 sessions in a hyperbaric chamber. This is from the blog Beata wrote as if she was Maya. I had again 5 days of hyperbaric treatments and 3 days of ketamine infusions, 3,000 milligrams total. I felt totally exhausted. I've been very forgetful from the ketamine. Short-term memory definitely is a problem. Sometimes I can't tell if it's AM or PM. Did I eat breakfast already or not? Did I have my ketamine treatment yet? Did I go into the chamber yet? Everything is just a blur to me. Dr. Hanna gave evidence explaining why he referred Maya to Johns Hopkins All Children's Hospital on the 7th of October 2016.
Did you talk to the psychologist at all in 2016 to get an idea of how Maya was doing from a psychological standpoint?
No, I did not.
No. Okay, so you sent her to Johns Hopkins All Children's Hospital?
Yes.
Why?
Because I failed to help her. There's nothing I could do. I told the mother, that's the maximum I can do. I cannot give her anymore. She has abdominal pain. I need her to go to a bigger place. They can maybe do some continuous infusion. First of all, we need to see why she's having abdominal pain. They can do some lab work, check, make sure nothing else is going on. If I couldn't control her with my average capability, with the maximum infusions I could do here, then it's just time for me to send her to another facility.
So is it fair to say that October 6, 2016, which was your last infusion date with her, that was the maximum that you felt comfortable with?
Yes.
Then let me draw your attention to your last infusion here. And the patient on that day is in 10 out of 10 pain still, with pain medications. And you now went up to 1,250 milligrams plus a 50 milligram ketamine bolus, and you did this infusion over a shorter period of time, 2 hours, which gets us to above 24 milligrams per kilogram per hour. What was the medical decision making about going up even higher on 10/6/16?
As you see, the day before she came with 10/10. She was screaming. She was crying from pain. Her mother stated that I cannot live. You know, she's in so much pain. She's screaming. She's up all night. Not giving her enough. She was not responding. There was nothing else I could do.
Over the course that you were doing these infusions, doctor, and I had 55 infusions here ranging from early January to October 6th of 2016. I also understand that you wrote several prescriptions for oral ketamine to be used at home. Do you remember doing that?
Yes.
As this story reaches the final chapters, we need to look at factitious disorders. Factitious disorders relate to the intentional induction or falsification of physical or psychological signs or symptoms. When there is factitious disorder imposed on self, the individual presents themselves as being ill, impaired, or injured. When there is factitious disorder imposed on another, the person fabricates, exaggerates, or induces symptoms in another person. The old term was Munchausen by proxy, the by proxy meaning someone else. Factitious disorders involve deception. In factitious disorder imposed on another, reported symptoms and signs found on examination are not explained by any medical condition from which the child may be suffering. Physical examination and results of medical investigations do not explain reported symptoms and signs. There is an inexplicably poor response to prescribed medication and other treatments. New symptoms are reported on resolution of previous ones. Reported symptoms and signs are not seen to begin in the absence of the carer. Over time, the child is repeatedly presented with a range of signs and symptoms. The child's normal daily life activities are being curtailed. For example, school attendance, beyond that which might be expected for any medical disorder from which the child is known to suffer. Feldman and Yates, 2018 note, in healthcare, treatment is often stepwise. A patient who presents with wheezing is given standard first-line treatment. If that doesn't work, as it won't in some patients, second-line treatment is used. If that doesn't work, then third-line treatments are prescribed. In situations of medical child abuse, nothing works. Diagnostic studies come back normal, inconclusive, or inexplicable. The pediatrician feels the dilemma of believing the history as given by the parent while not finding a diagnosis. The child begins to develop side effects to the medication. There can be a long process of referrals to specialists. Further, there are often more invasive procedures and trials of treatments, none of which is effective. What is also known is that often the perpetrators of factitious disorder imposed on another have a background in health, such as nursing. Sometimes they may present with factitious disorders in relation to themselves, then focusing their attention on their children. They may also lead quite dramatic lifestyles, with adverse events happening to them more than you would expect. However, it is too simplistic to say that the parent is doing it just for attention. It is far more complex than that. Each case will be different. For example, an ill child may prevent a father from going away on business for work, or an ill child may generate income from charities. Having an ill child may mean that the parent does not have to meet day-to-day responsibilities, and if the child is in hospital, the parent may also feel cared for by the staff. There is also a recognition that for some parents, there is a duping delight, where they can manipulate professionals into doing what they want, which can become a powerful reinforcer. There may also be an element of excitement and drama, and often parents who engage in factitious disorder imposed on another are active on social media, sharing photos of their sick child or giving very frequent updates. Whilst each case is different, there are certainly commonalities. One way to work out what is causing the child's symptoms is to separate the child from the suspected perpetrator of the abuse. This is known as the separation test. If the child's symptoms are being caused by the parent, separating the child from the parent will often alleviate the symptoms. It is usually not just a physical separation. Often the child feels much loyalty to their parent, and they may continue to act as though they are ill or disabled because this is what their parent wants from them. Therefore, contact over the phone or the internet will also usually be monitored. Often the parent knows how relevant the separation test is, and they may be desperate to prove that they are not causing a child's symptoms, even though they are. So, they may go to great lengths to make sure the child continues to present with the symptoms during the separation test. For example, they may try and put something into the child's food during a visitation, or they may say something to the child to make them continue to act in a certain way out of loyalty to them. Therefore, the guidelines for contact between the child and parent are strict and universally accepted. There is a lot of debate about who gets the diagnosis, the parent or the child. Whilst the parent, not the child, has the mental disorder, you cannot separate the abuse being perpetrated by the parent and the harm being caused to the child. The child's symptoms still need to be understood in the context of a factitious disorder imposed on another. Therefore, the term medical child abuse is often used by pediatricians. We are now coming to look at the trial in more detail. As well as Dr. Kirkpatrick, Dr. Hanna, and Dr. Cantu, Dr. Chopra gave evidence for the plaintiffs. Dr. Chopra is a board-certified anesthesiologist. In an email from Beata to Dr. Kirkpatrick, she writes, "The court requested another unbiased CRPS opinion to be done on Maya. I suggested Dr. Chopra in Rhode Island." Beata puts unbiased in quotes. These are some clips from Dr. Chopra giving evidence.
And what is the McGill Pain Scale?
The McGill University in Canada decided to see, okay, where do pain conditions stand? So they interviewed a bunch of people and they said, all right, where in this scale would you put your pain? Like pain from labor or pain from amputation of a digit. And so they drew a scale, and that scale, CRPS was way above anybody else. It was way above amputation pain, cancer pain, or even labor pain. If you go from the bottom, you can see, tension, headache, sprain, and so on. As you go up, then you see non-terminal cancer, chronic back pain, and as you keep going up, prepared childbirth is number 32, and then you keep going up, and then you come to amputation of a digit is 39, and then so forth, and then finally CRPS, often it was originally known as RSD, is rated as 46. So on a scale of 50, 0 to 50, CRPS is 46. Nothing is higher than that. It's such a terrible
Before we carry on looking at clips from Dr. Chopra giving evidence, I want to address the report that CRPS is the worst pain known to man. The McGill Pain Questionnaire was first developed in 1971 by Melzack. Its stated purpose was to provide quantitative measures of clinical pain and allow statistical analysis of data collected during clinical research and practice. In 2011, Melzack published a paper outlining the results from studies that used the McGill Pain Questionnaire. He placed the results on a chart. Coursalgia was top of the chart. As noted earlier, coursalgia is now called CRPS type 2. It accounts for about 5 to 10% of CRPS cases, and it involves a lesion to a nerve. This study will just have looked at patients with coursalgia. Another study placed CRPS types 1 and 2 about halfway. However, it appears that someone replaced coursalgia with CRPS and then shared the chart on social media, and that chart has now been replicated many times. Indeed, the one presented in court was made by someone with a Facebook page called Invisible Illness Artwork. Next to the chart, they write, "Here is my updated version of the McGill Pain Scale." However, there is no McGill Pain Scale. There is only a McGill Pain Questionnaire. There is also no academic literature stating that CRPS is the suicide disease, and this appears to be another urban myth. Let's go back to Dr. Chopra.
When I say that these patients have pain, we're talking about the world's worst pain. I mean, This pain is worse than amputation pain. This pain is worse than childbirth pain. But CRPS pain does not go away. It's there 24 hours, 7 days of the week, and it just stays on and on and on. In fact, their pain is always 10 out of 10. On a good day, on a very good, rare day, it'll be 9 or 10.
However, these are clips of Maya following Dr. Kirkpatrick's diagnosis of CRPS.
Showing that she was progressing, and I thought it was a very good thing.
But still not quite ready to walk?
Correct.
Okay, so she push herself around on her legs and like that, and obviously master a dolphin.
Let's finish the publishing.
And is that your wheelchair?
Yes.
And y'all kept it right in that spot?
It moved a little bit, but mainly in that area, yes.
All right, and then when she wanted to get out of the pool, how'd you get her out of the pool and into the wheelchair?
At this point, she had enough upper body strength to pull herself out and then grab the wheelchair and push herself up.
26:59 on July 28th, 2016. Okay. All right, and the date on that, the record reflect is April 30th, 2016.
I go around that 6 times, so that's 5.5 miles. And I'll do some cardio, so running. I could do some high intensity interval training, so 20 seconds of running, 10 seconds of rest, so on and so forth for however long.
Let's go back to Dr. Chopra.
You can tell physically she's doing better today than she was when she was brought into All Children's. True?
All I've done is see her from a distance. That doesn't mean that she can't be in severe excruciating pain. The next thing is you look at color change.
Significant about the knees here.
So you can see how her knees are different colored. In fact, the left knee is a little darker than the right. The one on the forehead, these are classical CRPS lesions. The lesion that she has is extra painful, and she has one on the forehead, and then she has one on each hand. This is not a continuous line. It's a series of blisters, and they've all connected to each other to form a line. Okay.
What, if any, effect in your practice as a physician does having this Munchausen by proxy in the record?
Okay, I have an opinion on this.
Please.
Can I say? Okay. For one, they. Well, the jury needs to know the truth.
Sir.
If I were, as a physician, and with 30 years of experience, if I saw the word Munchausen by proxy, I don't want that patient.
Dr. Chopra's statements about Munchausen by proxy, or factitious disorder imposed on another, reflect what he states on his website. On his website, he states, "Child abuse pediatricians are a class of doctors who are pediatricians who specialize in diagnosing child abuse. This path of specialization is obviously not chosen by the pediatricians who are academically good. As a result, these child abuse doctors are not the best to identify complex medical conditions, let alone straightforward common medical conditions. Admittedly, there are parents who should be penalized for child abuse, but those are very obvious, such as drug addiction, molestation. This does not mean that a worried parent of a child trying to seek the right medical care should be accused of Munchausen by proxy. Avoid any hospital that has a child abuse doctor on staff." These are some clips from Dr. Kirkpatrick giving evidence during the trial. He also talks about his assessment of Maya. You saw clips from that assessment earlier. The video of his assessment was not shown in court.
And where do you live?
My home address is 849.
You don't need us to give us your home address. Just
We're
county.
Okay, sorry. Hillsborough County, Tampa, Florida. In a situation like this, it usually takes at least an hour to get through an evaluation. You have to look for everything, because that's part of making the diagnosis. You have to rule out all the other possibilities based on the history, based on the symptoms, based on the signs that you witness. You have to be able to rule out these other potential diagnoses, or at least you can come up with a differential diagnosis may include more than one thing wrong with the patient. Well, I have a pretty much a head-to-toe type of examination, because remember what I said, you got to look for all the possibilities here, not just one thing that you've been doing research on. Is I want to set things up and do things that leave me convinced that I've done a very objective evaluation. But when she came in, the one thing that stood out more than anything else is her skin was exquisitely sensitive to light touch. So I measured for differences in temperature. Now on this particular occasion, there was some difference, but it didn't reach my satisfaction for a significant difference from a medical standpoint. So I didn't record that there was a difference in temperature.
Okay.
Keep in mind that this is a disease that's labile. You come in one day and there's a difference, one side's warmer, one side's colder. If you think about it, there's going to come a point where they're kind of they're the same.
Did you warn off Sally Smith from accusing this family of Munchausen by proxy?
Yes. And the other part of it, Counselor, is that I emphasize that if she doesn't get the ketamine, it's going to be a slow, painful death.
We also know that Dr. Kirkpatrick has said that other patients of his are dying. For example, in this article from 2012, he was reported to say that this is a disease where we treat quadriplegics because their body is shutting down. Patients like Mirsky are basically dying. While sadly Maya's friend Jessica died, this was due to sepsis, this being one risk of ketamine comas. CRPS does not lead to death, although death is something that Beata often talked about in the blogs she wrote as if she was Maya. She is also noted to have spoken to a pharmacist about Maya being terminal. Dr. Kirkpatrick said that he told Dr. Sally Smith that Maya would have a slow and painful death if she did not get ketamine. Dr. Sally Smith did not agree. However, Dr. Kirkpatrick told Beata how he felt about Dr. Sally Smith as he wrote in an email to her. Dr. Smith is a dangerous doctor and must be disqualified as a medical expert in this case. Dr. Smith and her friends at Children's Hospital are accusing you of Munchausen by proxy as a scapegoat to conceal their obvious incompetence in the care and treatment of your daughter. I think Beata must have been very confused. Let's try to put this all together. Maya's was a complex case, requiring a multidisciplinary team approach to unpick what the cause of her presenting problems were. How much was caused by Beata potentially having a factitious disorder imposed on another? How much was caused by Maya potentially having a conversion disorder and a belief that she needed to be in a wheelchair? How much was caused by Maya potentially having a factitious disorder and purposefully not using her legs or turning her feet inwards? Perhaps because of habit, perhaps because she liked it, or perhaps because she thought it was what she should do. And was CRPS relevant? If child medical abuse is suspected, the priority must be protecting the child. However, the separation test also helps to work out what is contributing to the presenting problems. Let's take the position of Maya's feet. When Maya was in Mexico, could Beata had repositioned her feet before taking photos? This is something a person with a factitious disorder imposed on another might do. Remember the duping delight. Or could Maya's feet be turned inwards because she believed that she could not use them normally? That would be a conversion disorder. Maybe her feet were turned inwards because it was a symptom of her having a factitious disorder herself. I would have said maybe it was due to CRPS. However, the dystonia present in CRPS is due to physical changes such as muscle contractures, swelling, and tightened skin, and Maya did not present with these observable signs. But what we do know is that the therapy for a conversion disorder, factitious disorder, and CRPS are the same. Physical therapy, occupational therapy, and psychological therapy, including art and music therapy for patients who are not ready for the more intensive talking therapies. We also know that it takes time, especially in a case as complex as Maya's was. And so we have it. I have come to the end. I know what I think about it all, but the questions I would ask you to consider are, Did Maya need to be the youngest child to undergo a 5-day ketamine coma? Did she need a ketamine coma at all? Had all other treatments been tried first? Should a 10-year-old child be given the choice of whether to accept a treatment with a 50% chance of death? Did she look like she needed such a risky intervention? Why did the anesthesiologist not seek a psychological assessment first? If she had CRPS, why did 55 ketamine infusions not help her? Why would she also need 40 sessions in a hyperbaric chamber? How would all that affect a child's health, thought processes, psychological well-being, and activities of daily living? Why did Beata want Maya to keep a port in her body? Why did Beata say Maya was terminal? How much did Dr. Kirkpatrick's and Dr. Chopra's views about medical child abuse pediatricians affect the way Beata saw the situation? Why would so many professionals risk their careers to harm a 10-year-old child? Do we really think that they would harm a child just because the mother was argumentative? Would it not be more likely that Beata saw things how she did, as she was angry because a hospital would not accept her reports that her child was severely ill and give her the medications she wanted them to? Would it not be more likely that a 10-year-old child's perception of events was heavily influenced by her mother? Can we really rely on the memories of a 10-year-old child as being fact, even if they believe it to be true? Why would we take the recall of a 10-year-old child as more reliable than that of so many professionals? Why would we consider the evidence of doctors who state that medical child abuse physicians should be avoided as more important than others? And why might they state that? Is it usual for a doctor to say to a patient that other doctors torture them and that the only way of seeing things should be from their point of view? Most importantly, did Beata have factitious disorder imposed on another, and was Maya the victim of medical child abuse? And if she was, what could have happened if Johns Hopkins All Children's Hospital had not intervened? Where could we be today? As said, I know what I think. The last chapter. I began by saying that I wanted to tell you a different story, one not shown in court. I want to end showing you Maya now, a vibrant young lady with a full life ahead of her. We are all the authors of our life stories, and a new chapter in life is waiting to be written.